Hello, everyone. My name is Jeanette Lopez Bellin. I am an epidemiologist for the City of Houston Health Department, and today I'm going to be talking to you about syphilis, how to correctly stage each one of the stages, and also the adequate treatment for each one of them. So let's begin talking about what is syphilis. Syphilis is basically a bacterial infection caused by Treponema pallidum, which is an spirochete, and because of its morphology, you can see that it looks like a corkscrew-like shape. And because of that, it's able to easily enter the skin of the person when an infected person gets in touch with somebody who is not. Syphilis has often been called the great imitator, and the reason for this is because all of the signs and symptoms that we see, they might be difficult to differentiate from those other diseases such in HIV and also like um, affections affecting the skin like eczema, etc. Now, about the stages of syphilis, it's important to know here that according to the stage, the dose of the treatment it's going to be different. For example, all of the earliest stages like primary syphilis, secondary syphilis, and also early latent syphilis, they require basically one single dose of bisaline in comparison to late latent stage, which basically it's given in 3 doses. But let's learn first about how we can distinguish between each one of the early stages. For primary syphilis, the main symptom that takes a role right here is the chancre. Now, let's talk about what is the chancre. Basically, the chancre, it's like a lesion appearing in the area that the bacteria was inoculated. So basically, it's going to appear at the entry side. What happened is that Treponema pallidum organism proliferates, and then basically it causes the formation of that primary lesion. And something very important is that chancre, it's painless, so it doesn't hurt at all, and this is very important to remark. This lesion, this chancre, it could appear, for example, in the genitalia. As you see right here, it's going to be basically round with demarcated borders. And then also it can appear in other regions such the oral cavity. So as you see right here, this is an oral chancre. Once again, it doesn't hurt at all. It's painless. And also it could be differentiated from another type of sores that could appear in the mouth, like the canker sores, for example. But the main thing to distinguish here is that it's going to be painless. In the case of the secondary symptoms, here we're going to see a lot of symptoms that are mostly systemic. So what this means is that at this point, the bacteria has basically reached the bloodstream and also the lymphatic system, causing all of them. So let's begin talking about the generalized body rash. The generalized body rash appears in more than 75% of the persons with secondary syphilis, and it's non-pruritic or non-itchy. It's going to be basically involving areas in the trunk of the body, such the chest and or the back, and also it could appear within the palms and also the soles. It generally appears after 4 to 10 weeks from the onset of that primary chancre. I wanted to make the distinction too about how that rash is going to look like in different skin complexions. For example, in light skin complexions, it's going to appear to be like more reddish or erythematosus. It could be also be peeling off or esquamosal, and it's non-pruritic once again. See the difference in darker skin complexions. For example, this rash is going to look more like dark spots, and basically patients may not differentiate they're having like a rash, for example. It's very important to distinguish according to the skin complexion. Other secondary symptoms that we're going to see on secondary syphilis, we have the mucus patches. These mucus patches, as you see right here on the surface of the tongue, they're going to look like lesions. they are going to be actually happening in about to 6 to 30% of the patients, and they can manifest as flat patches located in the oral cavity, the pharynx, the larynx, even the tongue, and also on the or inside the genital region. In the case of the condylomata, this is basically happening in approximately 10 to 20% of the persons with secondary syphilis, and they are going to be appearing in areas that are moist. And also they're going to look like wart-like papules, and also they can occur in warm areas such the gluteal folds, the perineum, and also the perianal region. Something very important to remark about the condylomedullata is that these lesions are highly contagious. The reason it's because the bacteria it's located within them, and it's considered a secondary manifestation because not only the bacteria is going to be located within the condylomedullata lesions, but also they are going to be disseminating into the bloodstream as well. Other symptoms that are also classified as secondary, we have the alopecia. The alopecia happens in about 5% of the patients that has syphilis. Something important to remark is that it could go also unseen in the female population, and also it follows like a pattern. Okay, it's also called the mud-eaten type alopecia, and it's gonna be basically appearing in areas of the scalp, like in the back of the head or occipital region, or on the sides of the head or temporal regions. Also, we might see that some patients, they will have loss of the lateral region of the eyebrows, and this is also considered alopecia. Other secondary symptoms that we're going to find in secondary syphilis, it's lymphadenopathy, which is basically swollen lymph nodes. It happens in about 50 to 86% of the patients, and it might be diffuse. Other systemic symptoms we can encounter malaise, fever, and any other non-specific constitutional symptom. We can also find visceral organ involvement. In some cases, the bacteria it's able to reach visceral organs such the liver, the kidneys, also the GI tract, and also the spleen and lungs. But the most common organs that might be involved are basically the liver and also the kidney. So that's why it's important that the provider, besides conducting or basically doing the serological testing to diagnose the syphilis infection, to also do an alkaline phosphatase. And this is just to determine if these organs has been reached or targeted by the infection. Let's talk now about the differences between latent syphilis. And I'm going to make distinction here because basically if the latent affection it's considered early, the treatment is just going to be different than the latent syphilis. So here, when we talk about latency, we're talking about time of evolution. Okay, for example, if the infection basically has been occurred within or less than 1 year of duration, that's considered early. But if the infection is of a known duration and the time of evolution is longer than a year, that's basically considered latent syphilis. Now, about the symptoms, here it's important to make the distinction that in late latent syphilis, the patients are going to be asymptomatic, okay? In the case of the early latent syphilis, they might be asymptomatic too, but also they might have like unequivocal symptoms. What this means is that basically these symptoms are not as specific to the infection. They don't remember the onset, the duration, and also basically they can remark symptoms, or they can be differentiated from symptoms that also occurs in other infections such HIV. Other way how we can determine that the patient is an early latent, besides what I have mentioned, we have to take a look also to the titers on that RPR. If we see a documented seroconversion within the past year, that's saying that the patient was early. And also, if we see a fourfold increase or greater, we're going to see that that's also falls under this category. Now, the important part of managing well syphilis, like treating patients adequately and also staging the patients correctly, it's because of the rise that we have been seeing in congenital syphilis cases. Why this is important? The reason is that syphilis is not only transmitted sexually, also it could be transmitted vertically. So what that means is that the pregnant person can transmit the infection to the unborn fetus or baby at any trimester in the pregnancy. So the thing with this is that it causes a lot of complications and also deformations, for example, in the baby, and also it causes stillbirths or fetal demises. About the birth defects, we're going to see malformations such the Hutchinson's teeth, as you see in this image. Also, bone abnormalities like the lower bones, for example, they're bending to the sides. And also, we're going to see developmental delays. About the testing, syphilis testing, basically we use serology. We're going to be using a non-treponemic test in addition to a treponemic test to confirm. In the case of the non-treponemic test, we have the RPR or VDRO. This one, we have also to measure the titers. So it has to be also quantitative and qualitative. And then we confirm with the treponemic test, which is basically the TPPA or treponema pallidum particle agglutination. If it's positive, then syphilis, it's basically likely. It could be any stage, past or present. Also, we are encouraging the medical provider population or community to not use or to avoid using FDA ABS. Why is this? Because basically we have found that FDA ABS gives a lot of false positives, and then basically um, these patients, they are diagnosed with an infection they don't actually have, and then therefore I'm going to explain to you why it's very common to see that they come back positive. For example, pregnancy triggers that, or any other infection, including UTIs or even upper respiratory infections or immune diseases trigger this FDA to be very to be positive because it's very sensitive. So we are encouraging and also recommending to use TPPA or treponema pallidum particle agglutination to confirm syphilis. About the treatment, basically the treatment is going to depend on the stage of syphilis. If the stage is early, regardless of its if it's primary, secondary, or early latent, so the treatment, it's going to be with gold standard, which is basically benzathine penicillin G or Vicillin with just one single dose of 2.4 million units given intramuscularly. Uh, Now we're basically facing a challenge, which is the penicillin or Vicillin shortage. So we're reserving this Vicillin medication only for pregnant persons. And then therefore we have other adequate alternatives for non-pregnant patients, and also people who doesn't or who has like true allergies to penicillin, which is basically doxycycline or tetracycline. Doxycycline should be given 100 milligrams twice a day for 14 days for all of the primary stages, early stages, primary, secondary, and early latent. And then doxycycline 100 milligrams twice a day for 28 days for late latent stages. In the case of pregnant persons, we're going to give basically Vicillin, 7.2 million units in 3 doses at 1 week intervals, no longer than 9 days. If not, then the patient would need to be restarted. But what about if the patient is allergic to penicillin? So then, therefore, that patient should be referred for penicillin desensitization, and then, therefore, they're going to be able to be adequately treated for their corresponding stage.
Hello, my name is Austin Bonnet, and we're going to look at a snapshot, syphilis in Houston. Over the next few slides, we're going to get a better understanding who is affected by syphilis and where it is spreading. We'll do this by syphilis stage, sex at birth, race, ethnicity groups, age groups, and spatial hotspots. These will each also be stratified by male and female. Here we have the annual syphilis case count for all stages for the Houston area from 2017 to 2022. The dark bar represents total counts by year, and the dotted line represents the slope over time. As you can see, there's a dip from 2018 to 2019, then an increase in 2020. This is likely due to the COVID-19 pandemic decreasing accessibility. Here we have the similar graphs stratified by male and female. Male is represented by the red bar, while female is represented by the purple bar. On the left, we're looking at case counts, and on the right is case rate per 100,000. As you can see, both groups are increasing. However, notice that the majority of cases are made up by male, though this is pretty normal, and even at a national scale, there's similar trends. Here we're looking at annual case count by stage. The pink purple bar represents primary, secondary, early latent stages, while the green bar is late latent. At around 2019, the primary, secondary, and early latent passed up the late latent. Both of these bars are increasing. However, the primary and secondary is 3 times the rate of the late latent. And this is important because the primary and secondary stages are the contagious stages of syphilis. Here we have a similar graph, stratified yet again by male and female. On the left represents male and the right represents females. As you can see, the male group increased, the primary secondary group passed the late latent in 2018 and 2019, while in the female group, it was in 2021 when the primary and secondary passed the late latent. Again, this is probably because the symptoms in males are more obvious. Though both these graphs have slightly different shapes and patterns, they're both increasing. Here we have annual case rate by race, ethnicity group. As you can see, annual syphilis rates have increased across all groups. The top group is African American, represented by the yellow bar. The purple one, pink color, is Hispanic, and then the blue bar represents white. The Hispanic cases, the African American cases are 3 times faster than the Hispanic cases and 4 times faster than the white cases. This graph suggests that people of color are disproportionately more affected by the syphilis outbreak. Here we have race, those stratified by male and female, left representing male, right representing female, and we can see similar trends. Both male and female cases, the annual syphilis rates have increased for each race group. Both male and females, the non-Hispanic black group has the highest rate. Here we're looking at annual case rate by age group. The annual syphilis rates have increased for most age groups. The highest is among the 20 to 24, which is represented by the yellow bar, and 25 to 34, which is represented by the pink bar. Notice that these are very similar in trends and slopes almost line up. This suggests that younger individuals are more affected by syphilis. Here we're looking at age groups stratified by male and female. Again, male is on the left, female is on the right. For both cases, every single group is on the increase. For males, the age group with the highest rate is 25 to 34, and for females is 20 to 24. This suggests that younger females, when compared to males, are more affected by the syphilis outbreak. Also, if you look at 15 to 19, notice that on males it's the lowest, and on females it's in the middle, which again reinforces, as I mentioned, that younger females are more affected by the syphilis outbreak compared to males. Here is age group breakdown by race and ethnicity group. Looking at each of these individually, the distribution is roughly the same. However, notice that every single one has 25 to 34 being the highest. The non-Hispanic black ages 25 to 34 make up majority of syphilis cases at 19%, followed by Hispanic ages 25 to 34, which makes up 14%. Here's age group breakdown by race, ethnicity group, and sex at birth for non-Hispanic, Black, and Hispanics. The African Americans represented by the yellow bar, and the Hispanic group is represented by the pink red bar. For males, the highest proportion of syphilis cases are non-Hispanic Black males from 25 to 34, followed by Hispanic 25 to 34. And for females, the highest proportion is 25 to 34, and for non-Hispanic Black is 20 to 24, which reinforces, as I mentioned earlier, that younger females are more affected when compared to males. Here are some summary points. Syphilis in our jurisdiction has been on the rise since 2017. Increases are seen across clinical stage, sex, race, ethnicity, and most age groups. A majority of our cases are male, which is also the highest case rate. However, syphilis is increasing in females also. There are potentially different behavior and trends when considering clinical stages of other demographics. We see highest rates in non-Hispanic Blacks overall in both males and females separately, age groups covering 20 to 34 overall. Rates in males slightly skew to older groups, and females' rates skew slightly to younger groups. The majority of syphilis cases are non-Hispanic Blacks from 25 to 34, followed by Hispanic ages 25 to 34 overall. This table represents annual congenital syphilis case rate by infant sex at birth. Between male and female, they kind of go back and forth, but as time progresses, they are evened out. But to me, what I find important is looking at the total column on the far right. As you can see, it has steadily increased over time. Now we're going to look at hotspot analysis for syphilis. These maps were produced using ArcGIS heat map feature. They show the relative density of points with a color scale ranging from cool colors or sparse density to hot colors, which is high density. This spatially allows us to see where our cases exist at a different level than a zip code map, while still maintaining privacy and confidentiality. This first map is looking at all stages: primary, secondary, early, and late latent. As you can see, the biggest hotspots kind of in the center. This is a mix of Midtown, Downtown, Montrose, and the Med Center. This is a high density populated area, so it's safe to assume that's one of the many reasons why there's such a high prevalence of syphilis in that area. Other hotspots consist of Southwest Houston, South Houston, and far up North Houston. Here we're looking at the same map, however we're only looking at male cases. This has extremely similar trends to the previous one. The hotspots in that center, as I mentioned before, the Midtown, Downtown, Montrose, Med Center area, Southwest Houston, up north, and a little in the south. Here we're looking at female groups. Notice the trends are significantly different. There's a higher proportion or higher density southern Houston. Other areas such as 5th Ward and Southwest Houston are also greatly affected, and similar hotspots up north.
Hi there, my name is Elliot Davis. I'm the policy analyst with the HIV, STI, and Viral Hep Bureau, and I'm just going to do a very quick wrap of this presentation with some information about the structure and activities of our response to the Houston Health Department. So this slide gives a brief overview of the 6 components of our outbreak response. I won't spend too much time here because this last slide gives a better idea of the functions and strategies of each component. So this first one you see in the top left is enhanced surveillance, evaluation, and planning. And essentially, the quickest explanation of this team's function is they are monitoring the reported cases and analyzing the data to inform our response overall. The next one below that is enhanced clinical operations, and they're looking to maximize capacity, efficiency, and effectiveness of not only our clinical operations here at the health department, but providers and practices community-wide. They do this through direct outreach and education to external partners and providers to increase awareness and best care practices, and also by connecting resources to ensure greatest accessibility to treatment for all members of the community. In the top middle here, it's disease investigation and public health follow-up. And this team is aiming to intervene in the outbreak by identifying undiagnosed infections through various methods to interrupt the chain of transmission. So what this looks like usually is following up with newly diagnosed individuals to help anonymously notify their partners who potentially contracted the infection and connect them with testing and care resources. The next one at the bottom middle is outreach services and education. And this team is providing education and testing and care services directly to the community in a manner that ensures the greatest level of accessibility. So to date, they've been partnering with community-based organizations and using mobile outreach units to bring testing to the areas with the highest need. Public information and awareness is exactly what it sounds like. This team has partnered with our internal communications team, as well as several news and media outlets to get the outbreak messaging and available resource information to the public. We've stood up a brand new dedicated syphilis webpage, which we've designed to be a one-stop shop for all relevant content related to syphilis, including educational materials and recorded presentations, town hall meetings, etc. And last but not least is community mobilization, and this is the team that I've been co-leading. And our main objective is to ensure the coordination of resource and information sharing across key community groups. To do this, we've been delivering education presentations to both internal and external partners. And I mentioned the clinical outreach efforts earlier to providers, so we've largely been focused on agencies and organizations in the non-service realm, but also that have strategic connections to communities with the greatest need or risk. We've also been surveying community-wide to not only inform our efforts, but also gain a better idea of our partners' testing and care capacity in attempts to maximize resource utilization. And I would love to thank you guys for taking the time to listen to this presentation. If you have any questions, our contact information is on the syphilis webpage, and please don't hesitate to reach out to me directly, elliot.davis@houstontex.org. Thank you.